This is eCancer Television, reporting here from Rome at the Blood Cancer in the Elderly Conference. And Evangelos Terpos, Professor Terpos, you're here from Athens. You've got some great data from Greece, I know, and you were an expert commentator at this session on multiple myeloma. We're looking specifically at older patients. Now, one of the topics we heard about was maintenance. What do you think is the maintenance? You listened to Gareth Morgan's talk, I'm sure. And what do you think is the position of maintenance in elderly patients?
I think that during the last years we have a lot of interesting data about maintenance therapy in myeloma. In other hematological malignancies like acute myeloid leukemia, let's say, or acute lymphoblastic leukemia, we have after induction therapy, we have consolidation and maintenance therapies that have increased the survival or even the cure rates in these diseases. So I think that it's time now for myeloma to change a little bit of our managing our patients. So we have two major studies in the non-elderly population, meaning patients who are eligible for a transplantation. And in these two studies, lenalidomide maintenance have increased progression-free survival time, something which is very important. And in the French study, the p-value was incredibly high of the survival difference regarding progression-free survival. So I think that from that study, we are going to have also overall survival benefit. So regarding the elderly population, we have one study, the MPR, melphalan prednisolone plus lenalidomide, and lenalidomide as maintenance. And we have seen from this study that the maintenance with lenalidomide, even in the elderly, has produced very encouraging results, meaning that it has prolonged the progression-free survival time.
Gareth Morgan was saying that the IMiDs are floating to the top in terms of which agents to use in the maintenance role, but he was also talking about ringing the changes, having one IMiD and then maybe another. What do you think about that?
First of all, the immunomodulatory drugs, and mainly thalidomide and lenalidomide, are oral drugs, so it is very convenient to give them as maintenance because the patient has not had to come to the hospital once or twice per week like bortezomib, let's say. So this is one advantage. The second advantage is that the way of action of immunomodulatory drugs, and mainly of lenalidomide, which is more potent than thalidomide, is that because of the reduction of tumor load, but also because of the immunomodulation that they create, they enhance the immune system against myeloma cells. I think that mainly for this reason, lenalidomide seems to be ideal for a maintenance effect. And that's why I'm very much interested not only in this study, which may give the MPR plus maintenance lenalidomide, which may give a license for this drug as the first drug for maintenance use in patients with multiple myeloma, but with MPR as induction. But also I'm very much interested to see what's going to happen if we use any other induction regimens like MPT with thalidomide or MPV with bortezomib, and then to have lenalidomide as maintenance. So I think that we have a lot of new information that are going to appear during the next years in order to see what's the exact role of lenalidomide as a maintenance.
What do you advise very briefly in practical terms doctors with patients in front of them right now should think about this maintenance issue then?
I think that we have to think about maintenance very clearly, and I strongly believe that after 1 or 2 years we are going to have a maintenance license, because this is the main problem. All the studies have shown progression-free survival benefit regarding lenalidomide maintenance, but unfortunately we don't have the license yet. So although I strongly believe that the maintenance is going to be very good regarding the progression-free survival in myeloma patients, of course we have to wait till the license from EMEA or FDA in order the doctors to use this drug as maintenance.
Of course, one of the things about the IMiDs is they may be less toxic, relatively low toxicity. So does that make them more suitable for elderly patients?
I think that one of the major advantages of IMiDs, and mainly of lenalidomide, to be honest, you see that I talk mainly about lenalidomide because for thalidomide the effects are good, but not so substantially, not so good like lenalidomide. Of course, we don't have a randomized trial comparing thalidomide and lenalidomide maintenance, but from the trials that we have till now, the lenalidomide effects are better. So I believe that first, they are oral drugs. Second, their safety profile is good. And with the lower doses that we use for maintenance, I think that they are very suitable even for the elderly patients.
So just a very brief final word of a practical comment from you for doctors about toxicity in the elderly then with some of these agents, both in maintenance and induction, very briefly.
I think that with lenalidomide and the low-dose lenalidomide, like 10 or 15 milligrams that are used in most of the studies, I think that this type of maintenance is very suitable even for patients who are elderly, even above the age of 75.
Evangelos Terpos, it's a real pleasure to have you again with us here on eCancer Television.
It's also a pleasure for me.